Dr. Lambert, welcome to the Tick Bootcamp podcast.
Thank you.
We are really excited to have you, and I'm sure folks have already detected you're a brogue. So why don't you first share with us a little about your background and where you're from?
I work in Dublin, Ireland right now, but I'm actually Scottish. So I was born in Scotland. My parents immigrated to America. That's why I have an American education. And then I moved back to the UK in 1999, and then ended up in Ireland. And I've been there for the last 18 years as an infectious disease specialist. So that's my short synopsis of my life.
All right, so build out a little bit more your education in the U.S. So where did you go to college? Where did you go to medical school? And you also have a PhD. So why don't you build that out for us?
I actually went to college in Kalamazoo, Michigan. So my parents immigrated to Indiana. So I went to college in Indiana. I went actually back to Scotland for a period of time to go to the University of Stirling. And then actually realizing how difficult it was kind of being in that transition. I was looking to go to medical school in Scotland, but the system is quite difficult once you've left the country. So I finished my university degree in Michigan, and then went to medical school at Michigan State University. Always interested in infectious and tropical diseases. So that was always an interest of mine. And when I completed my training, moved out to Rochester, New York, completed my training in medicine and pediatrics. And then, so I'm qualified as a general pediatrician, a general internist, and then completed my infectious disease training in Rochester, New York. So I jointly in pediatric and adult infectious disease. And then my first kind of worked in academics at the University Hospital in Rochester for a couple of years, and then moved down to Baltimore, where I worked 3 years at Johns Hopkins and 3 years at the University of Maryland Institute of Human Virology before, kind of long story, but I had 3 kids. I was raising them on my own. Being in Baltimore was quite a challenge, and I kind of made the decision to move back to the UK, more for family reasons than professional reasons, because I had a really great job in Baltimore. So my experience in Baltimore, was infectious diseases, mostly virology. But I did learn a lot about tick-borne infections in my time in Rochester, my time in Maryland. And then I moved back to the UK in 1999, worked for 5 years in the UK before I found a job in Ireland, kind of the job that I had that was kind of similar, in terms of quality as the job I had in Baltimore. And my plan has always been to move back to Scotland, but I haven't quite made it back there yet. So I continue working in Dublin, Ireland, as a professor at the UCD School of Medicine and a consultant in infectious disease at the Mater Misericordiae University Hospital. So it's the teaching hospital of the UCD School of Medicine. And I also run clinics at the big maternity hospital in Dublin, because one of my interests in pediatrics and maternal fetal transmission, I run a big clinic in infections in pregnancy at Rotunda Hospital, which is one of the big maternity hospitals in Dublin.
Wow. So that's a pretty impressive resume. So talk to us about how you got to where you are now. Meaning, when did you first develop a passion for the healing arts? Did you know you wanted to be a doctor from an early age? Or was that something that developed in you, that desire developed in you later on in your life?
Yeah. No. I think I always was kind of programmed to go to medical school. I don't know why. It was always something I was interested in doing, but I kind of saw myself working more in tropical medicine. This was before HIV came along. So I was kind of interested in tropical infectious diseases. I actually did a stint leaving Rochester and going down to Baltimore. I worked in Haiti for a while at a mission hospital there. So I always kind of had interest in working kind of international, working in tropical diseases. And actually, when I started working in Rochester in my fellowship, I was working on dengue fever. I was working on yellow fever vaccines. I was more involved in tropical medicine. And then HIV came along. This was in the the 80s, and I was in New York State. So a lot of my early work kind of shifted to HIV. A lot of my research work moved to HIV. And I was one of the first people actually to work on mother-to-child transmission of HIV and working on pediatric AIDS. So that really kind of was my kind of claim to fame in America, was work, I was jointly qualified in adult and pediatric infectious diseases. Nobody was really interested in taking care of the children at that time. Nobody was interested in taking care of the pregnant women. Everybody was afraid of HIV and AIDS. The obstetricians wanted to protect themselves. They didn't want to take care of the pregnant woman. So I developed an interest in infections and pregnancy, with HIV being, kind of the main thrust of my work. So I've actually developed programs for through the AIDS Clinical Trials Group in America on treatment of HIV in children, treatment of pregnant women with HIV. And then a lot of my research early on was work through NICHD, National Institute of Child Health and Development. I obtained a number of grants in the US before moving back to the UK, focusing on pediatric AIDS and mother-to-child transmission of HIV. So that was kind of my work prior to moving back to the UK and Ireland.
So talk to us about first, what is an infectious disease doctor, and what was it about that discipline that attracted you to the infectious disease space?
Right. Well, first off, I never liked surgery. So I could never be an obstetrician. I don't like blood. I could never be a gastroenterologist. I don't like the smell. I could never be a cancer doctor because I don't like to see dying people. So I guess the thing that really kind of excited me about infectious diseases, you actually have the ability to cure people. This is kind of the challenge, and even with HIV, it's not curable. I had reservations about going into HIV because they were all dying in the early 80s, but actually becoming a part of that effort. We now have treatments for HIV. You can't cure HIV, but people live a normal lifespan. So my interest had always been curing people, and infectious disease is one of the few, I think, disciplines in medicine where you can actually potentially cure people. So that really has always been my what kind of keeps me running, keeps me excited about working in medicine, the opportunity to cure people, get them better.
So let's define infectious disease doctor, because we interview many different people on this podcast. We're at well over 400 at this point, and each of you looks through a very different prism. So give us a definition of infectious disease and the prism through which you look through when you're diagnosing and treating a patient.
Yeah. Well, I mean, infectious diseases are pretty much everything. There's bacterial infections, there's fungal infections, there's viral infections, there's spirochete infections, which are a form of bacteria, which Lyme diseases. There's infections that, so different. So there's so many opportunities in infectious disease. Like recently, I've attended an infectious disease conference, in Boston, and you get to get updates on coronavirus, COVID-19. I just listened to, presentations on HIV and AIDS. I listened to presentations on tropical medicine, travel medicine, developing new vaccines for chikungunya, which is a viral infection that is spread by mosquitoes. So it's such an exciting area, infectious diseases, because there's so many different areas that you can work in. You can work in virology, you can work in transplant medicine, you can work in HIV care. To me, it's one of the most exciting areas of medicine because it's challenging, because people present with such a myriad of symptoms. It's not that clear cut when somebody walks through the door. Their liver's inflamed, their kidneys are not working, their brain's not working, their platelets are low, their hemoglobin's low. They have these undifferentiated fevers. I mean, I think it's an absolutely exciting area to be involved with. It's kind of like a Sherlock Holmes type thing. And one of the doctors I worked with in America, who kind of mentored me in Rochester, New York, there's a textbook of infectious disease called Mandel, Douglas, and Dolan, Practical Principles of Infectious Disease. My boss was a guy called Ray Dolan, who then moved on to be, associate dean at Harvard Medical School after he left Rochester. And he basically taught me that, a good infectious disease specialist is a good internist. We take care of every organ system. Infectious diseases damages every organ system. And rather than saying, the kidney problem is separate from the heart problem, it's separate from the lung problem, it's separate from the brain problem, we kind of put these problems together into one unifying diagnosis. And that kind of excites me. That's what I really like is seeing patients with these, what I call mystery illnesses very often, and trying to figure them out. And once you figure them out, you potentially can get them better, which is absolutely rewarding.
So focusing a little bit more on the infectious disease element of the work that you're doing, and then I want to talk to you a little bit more about the tropical medicine. Let's say focus on the infectious disease. So would I be correct in defining an infectious disease doctor as a doctor who examines patients to determine the microbial cause of the multisystemic illnesses that they're presenting?
Absolutely. That's exactly what infectious disease doctors do, and then even more importantly, the other exciting part is being involved, not just in coming up with a diagnosis, but coming up with therapeutics. When I started in HIV and AIDS, there was no treatment. There was no drugs available. And then AZT became available. And then I was involved in the studies that involved the second drug, which was called DDI, and then I was involved in studies to treat pregnant women with the HIV medicine so the babies didn't become infected. So that's kind of the exciting part, is not just coming up with a diagnosis, but coming up with therapeutics to get people better. When I moved to Dublin, in 2005, there was no good treatments for hepatitis C. Now we have cures for hepatitis C. And I was involved in, working with the pharmaceutical companies and enrolling patients in studies to determine whether there was new drugs that worked better to treat people for hepatitis C. And now, those studies started all over the world, and in Dublin, where I worked, in 2008. And now we have one tablet that you can take for 8 to 12 weeks and cure people of hepatitis C, which is absolutely a miracle, So the exciting part is, as you said, of infectious diseases is coming up with the diagnosis. But to me, the equally exciting part is coming up with treatments that potentially can get people better.
And it seems to me that one of the things that's really exciting about doing the work that you're doing, in the spirit of defining you as a medical detective or a medical Sherlock Holmes, is that you're going to have a large number of microbes somehow getting into the human body, which is then going to interact with other microbes that the body has been harboring. And this multisystemic illness is going to present very differently in every single person. And as a result of it presenting very differently in every single person, when you're coming up with a treatment protocol, that's going to necessarily have to be individualized between you and your patient.
Right. And absolutely. There's, like I said, that's exactly the situation. And I think that applies to most infections. There isn't, there's guidelines, but you don't treat people by guidelines. You treat people according to their clinical response. And I say this all the time. The guidelines say treat a skin infections, a cellulitis, for 7 to 10 days. But in some patients, it takes 4 weeks of antibiotics to get the skin infection better. So I think, part of the art of infectious diseases is applying the guidelines and treating the patients, not the guidelines. And that really is, that really is the ongoing challenge for whether it's HIV, whether it's Lyme disease, whether it's COVID, long COVID, whether it's hepatitis C, whether it's tuberculosis. You have to kind of individualize treatment. And that's kind of the fun part. You're not following a recipe. You're actually trying to kind of monitor patients, evaluate patients, see if they're responding. If they're not responding, you modify treatment. But like I said, the exciting part is the end game is getting people cured.
And it is really the exciting part of clinical medicine. However, it's also risky. And one of the things that I really admire about doctors like you is you recognize that the treatment protocols that you're given are not going to apply to many of your patients. You're going to have outliers, and you're going to have to take some risks when you're treating an outlier, because you're not going to necessarily use generally accepted medical practices in order to be able to cure these people. And that, in many cases, has put some of the best Lyme doctors in a position where they find themselves coming up against medical boards, and in some cases being sued because the standard malpractice actions is generally using generally accepted medical practices. But quite frankly, if you're an infectious disease doctor, there really is no such thing.
Right. No, and absolutely. And I think that's really the situation. I mean, I've, gone back to the early days of HIV, the guidelines were to treat people with one drug, which didn't suppress the virus. So when 3 drugs became available, some of my patients came to me and said, I want to go on triple therapy. And my first response is triple drug therapy isn't approved. But then when you start thinking about it, the problem is not if the patient wants the treatment and the treatments are safe, then what's the downside of giving them triple therapy? The downside, there is no downside. The upside is that the guidelines a few years later changed to put people in triple therapy. So you don't always have to wait for the guidelines to treat people. I treat people with long COVID. There are no guidelines to treat long COVID. I've established my own guidelines, and I know the treatments I'm doing are getting people better because I monitor patients. I do questionnaires before and after treatment. I see how they respond. So I can be criticized using long COVID as an example for managing long COVID patients, but many of my patients get better. And most of the other clinics that patients go to with long COVID, they get test after test after test after test. And then they get basically told, all your tests are normal, get over it. Well, you don't get over it. So 5 years from now, we will have guidelines for long COVID. But I've started seeing long COVID patients 3 years ago, early in the first wave of COVID, and I started seeing these patients not getting better. So you start kind of looking at thinking out of the box a little bit, using off-license indications for certain treatments, and then when you see that those treatments work, you actually keep records, document, publish. And this is the thing that you can use to avoid the situation where, doctors are treating, off protocol, and they get sued and they get their license taken away. My approach is I can stand behind everything I do, and I can actually provide, detailed explanation. And if anybody says you shouldn't be doing this because it doesn't work, my response very simply is, well, I have publications to show it does work. You show me publications to show that it doesn't work, and they can't. So I think, sometimes you do have to stick your neck out, whether it's long COVID or Lyme disease or going back to the days of HIV. But as long as you can, practice good medicine, not do anything crazy, do things that are safe, and actually monitor, your treatment response and your patients, then, and be able to publish that, then I think that's the best defense.
So, one of the things I think is also exciting about interviewing infectious disease doctors, in many cases, there is a bright line between researchers and clinicians. But I think in your profession in particular, the line is not so bright. You are part researcher, part clinician when you're working with all of these people who are suffering from these multi-systemic diseases from polymicrobial infections. So you really have to sort of have a foot in each camp if you're going to be a successful infectious disease doctor. Do you agree with that, or do you have a different take on that?
No, I absolutely agree. But moving on to Lyme disease, for example, I think, I mean, one of the criticisms of Lyme disease is people do things that are way out there, and sometimes, but they don't record their results. There's more experts in the world on Lyme disease, but in some ways they're self-appointed experts, and if somebody criticizes them and asks them to kind of show their data, explain why they're doing what they're doing, show their success rate, they can't show it because they've never published, and this is really part of the challenge. So I think the biggest, like I said, the biggest strength that I have, or I think I was quite wary about getting involved in Lyme disease at one time because I was aware of the shark infested waters, but I think I kind of put together a plan and a strategy that if I was going to do it, I was going to do it in a way that would help patients, but also protect myself, And the way you protect yourself is you practice good medicine, you practice safe medicine, you record your results, you publish your results. And I've published, not to brag, but I've published, just using COVID, for example, and long COVID since 3 years ago, we've got probably 25 publications,
Wow, congratulations.
Just 25, and if you look at most of the quote unquote Lyme literate doctors, they claim to be experts, they claim to be widely published, but the way you find out if people are published is you do a PubMed search and you check on PubMed, you put their name in. And I actually did that today. Some of the experts, on Lyme, who claim to be experts in Lyme disease, but if you actually do a PubMed search, their publications are 1 or 0. This is their whole career, 30 years of their career. So I just think that the challenge really is that it's, I think Lyme literate doctors, are doing great work. But sometimes they really don't have the evidence to support the work that they're doing. And sometimes they make claims that they've done great work. Like, for example, I work in Ireland. A lot of patients in the UK and Ireland go to Europe to get private treatments in clinics. And, I've gone to some of the patient group meetings, and you have some of these centers in Europe that come and they say, we're a world, leading experts in Lyme disease, widely published, et cetera. Our data on hyperthermia for treatment of Lyme disease, shows that everybody gets cured. But when you actually look, they don't have any publications. They claim to have publications. So the dilemma of Lyme disease is, I think, really is that it's an unknown area. There's not good funding in the field. The Lyme literate doctors are not part of mainstream, and they're managing most of the patients, and many times they're doing good work, but sometimes some of the claims that they make are not backed by good science.
And I think that's an important lesson for our listeners to keep in mind, because part of making a decision about whether you're going to work with someone is an element of due diligence, and your due diligence should include speaking with other patients and certainly doing a PubMed search to make sure that the folks who are making the claims that they're making are not in fact snake oil salespeople, but they are in fact folks who are doing work on the research and clinical side that is respected and hopefully published, so that the results can be examined not only by the patients themselves but by other people to see whether or not the claims are replicable and can be supported by the general community.
Absolutely, and I think that's important. I mean, I see lots of really sick patients, whether it's long COVID or chronic Lyme, and they've gone so many different places, and they've been turned away, and they've been rejected, and they've had people get pretty desperate. People get pretty desperate, and like you said, sometimes they jump for the snake oil because they're desperate, and they're kind of misled. So I'm not saying every Lyme literate doctor is practicing that way, but I do think that you do have to have a high degree of skepticism, and you should do your homework. You should do your homework ahead of time to make sure that that your investment of money and time to get these treatments have a good chance of succeeding.
Yeah. So before Matt is jumping out of his seat, as you can see, so I do want to develop one other line with you, and let Matt start asking some of his questions. And that is, Dr. Lambert, we've found it a little frustrating as a podcast on Lyme disease when we've tried to ask people to come up with a definition of Lyme disease. And at one point I said to Matt, we have almost as many definitions of Lyme disease as we have people that we've interviewed. And I think it's one of the reasons why we have so many diagnostic challenges in the community, because it doesn't appear to be a consistent definition. So we've come up with a definition for Lyme disease here at Tick Boot Camp, and I'd like to run that by you and get your reaction to it. So our position is that Lyme disease is a polymicrobial, multisystemic, chronic infectious disease. What would your reaction be to that definition of Lyme disease?
Well, actually, Lyme disease refers to just one bacteria. And that bacteria that was discovered going back to old Lyme, Connecticut, was the bacteria called Borrelia. So actually, Lyme disease is one bacteria.
Well, so now let's explore that together. As an infectious disease doctor, the folks that you've treated, and we'll just focus on Lyme for now, have any of them really just been exposed to a single bacteria, or have you found with your patients that they have a polymicrobial infection, either because they were harboring bacteria and viruses and protozoa that their immune system was managing, and then this combination of new microbes being spit into them caused them to be sick, or were they overwhelmed by many microbes being spit into them by a tick that had bitten them? I mean, or has it been your experience that folks are sick from what we're now defining as Lyme disease when they get bitten by a tick, or it's passed on, in some downstream ways from only one bacteria?
Right. So you asked me for a technical definition of what Lyme disease is. So I think, in answer to your question, probably both things are going on. So the longer you have Lyme, I think the more damage it does to your immune system, the more immunocompromised you become. Kind of sounds like similar to HIV back in the olden days. The lower and lower your immune system you get, the more likely you are to catch other infections, the more likely you are to get reactivations of other dormant infections that you had in your system, bacteria and viruses. So I think, that long-standing Lyme disease causes a degree of immunosuppression. And in that setting, I think you get reactivation of a lot of endogenous infections that you had prior, or, that you could have had from childhood, who knows? Second thing is, ticks carry lots of different bacteria. We only focus on Lyme disease. In Ireland and UK, you can only get tested for Lyme disease. If you ask to get tested for Anaplasma rickettsia, et cetera, it's very difficult to get done. So I think co-infections are the rule rather than the exceptions. If you look at studies from, the Hudson, upstate New York, where they actually, biopsied patients with the ECM rash, and were able to isolate Borrelia. So you know that they actually were infected. Research laboratories can do that. 10% of them had Babesia. If you look at the ticks in Ireland, University College Dublin Vet School have done studies. They've taken the ticks, done PCRs on them, ground up the ticks and isolated the PCR, the DNA. They found Anaplasma, Rickettsia, Babesia, and Borrelia. So it's likely that when somebody's bitten by a tick, they have lots of different infections. There's a big outbreak now that's been publicized in the UK press about tick-borne encephalitis. Tick-borne encephalitis is highest numbers in record in Scandinavia this summer because of global warming. It's all over Eastern Europe. There's a vaccine for tick-borne encephalitis that you take if you live in Eastern Europe. The ticks are now kind of migrating on the geese, obviously coming over from Scandinavia, landing in UK, going into the grass and biting people. Now we're seeing people in the New Forest, which is the southern part of England, in Devon, which is also the southern part of England, and heading up northeast to Norfolk, and they're bitten with tick-borne encephalitis. So to support your point, we call it Lyme disease. People are beginning to kind of step away from Lyme and say Lyme and co-infections. I still think Lyme is probably one of the critical infections, probably one of the more pathogenic infections, but I think it is polymicrobial. So both bacteria, multiple bacteria that tick can inoculate into your body, and then lots of dormant bacteria. There's intracellular bacteria that people have, and there's viruses that people have that I think are getting reactivated in the setting of, chronic persistent Lyme and immunosuppression. However, it's not been well studied, and if you look at private laboratories, they'll have people test for, 15 different pathogens, and they'll do antibody tests, and they'll say, oh, you're infected with all these viruses and bacteria, and they are causing your symptoms, but you don't really know, because an antibody test, when you do these tests are your immunological memory. You need a PCR. You need to culture the bacteria, the virus, to actually prove that it's replicating. So we're still limited in our technology, and this is one of the challenges of tick-borne infections. Tick, Lyme, and co-infections is we've got poor diagnostics, and it's a bit of a guessing game, to be perfectly honest, as to what, if you don't remember the tick, if you don't remember the bullseye rash, when people present to you, since we don't have really good technology to prove active infection, it's a bit of, as a clinician, it's a bit of a guessing game as to what infection is actually in the system causing all their symptoms. But Lyme, in my opinion, is really probably the critical pathogen, and other infections kind of also can play a significant role. Viruses, bacteria, other infections as well.
So, Dr. Lambert, the laboratory piece of it, although for sure these direct detection PCR tests are probably better than these immune response tests, they're still not perfect, right? And we know from doing our research on you, Dr. Lambert, that you have an affiliation through your Lyme awareness not-for-profit and T-Labs and Dr. Robert Mazzayanin. We're going to get into all that, right? But we still know these tests aren't great. So understanding that tests aren't great for Lyme and various co-infections, and understanding that, as you said earlier, generally you as a practitioner, and again, I want to point out, you, I think, Dr. Lambert, are the exception rather than the rule when it comes to infectious disease doctors, right? Most infectious disease doctors do follow the guidelines, unlike you, right? Most infectious disease doctors do look at Lyme disease as a singular textbook definition, as you first described with Rich, which is Borrelia burgdorferi sensu lato, right? Are you infected with this? And they rely on unreliable tests to even prove if you have Borrelia burgdorferi. But myself and many others in the community get sick with Lyme and many other things for many, many, many years. We get treated with doxycycline or IV antibiotics. We don't get better. we're then told it must be something else, and we're left to suffer for quite a while because of all these things, right? So how do you as a practitioner overcome these problems? You mentioned that you have to do these types of publications to protect yourself as a doctor, but a lot of this you have to do anecdotal studies to then prove out these studies that you can publish, right? To then use that to protect yourself. So there's so many, I think, barriers here to treat people with guidelines that don't fit a lot of people, with bad testing, right? And then with this standard definition of Lyme disease, when in many cases it's much more. So how do you overcome all those hurdles as a practitioner treating people with Lyme disease and chronic Lyme disease or really aggressive Lyme disease in your field?
Well, you've asked me about 10 questions there. But look, if you look at the Irish guidelines say treat with 10 days of doxycycline, end of story, and you're cured. I mean, even today. And actually, I told you I'm at infectious disease meetings, and I was at meetings with some of the people who actually put together those guidelines. And they actually tried to put guidelines in 2018 in Ireland that even without treatment, Lyme magically disappears. It just goes away without treatment. So of course, yeah, there's probably 35 infectious disease doctors in Ireland, and there's one of me. So it really is a bit of David versus Goliath. But if you look at the infectious disease textbooks, I told you my mentor, Mandel, Douglas, and Dolan, which is a classic infectious disease textbook used by all infectious disease doctors in America, principle and practice of infectious disease. They say Babesia only happens in patients who've been splenectomized. Otherwise, you just magically get Babesia and clear it. So the challenge really is even beyond that, is that the specialists who are being trained in tick-borne infections, if you look at the textbooks that they're reading, that's what it says. It says Lyme, easy to diagnose, easy to treat. All these other co-infections are of questionable significance in humans. So this is really the challenge, that goes along. And you can't get funding for Lyme disease. The NIH, the National Institutes of Health in America, I think have come up with $5 million a year for Lyme testing. I just spent time at Infectious Disease Society of America conference, which is 10,000, infectious disease doctors from all of America, presenting data on HIV, with funding from the NIH. I mean, last time I looked at the National Institute of Allergy and Infectious Disease, they're funding 1.8 billion for AIDS, HIV research. And we already have treatments for HIV, good treatments that give people a life expectancy greater than somebody who's HIV negative, but we continue to put money into HIV, and we put almost no money into Lyme disease. I ran into one of my colleagues who is interested in pediatrics, and I asked her about Lyme in pregnancy. She's kind of a preeminent professor in Long Island. She sees lots of kids, and she says, well, I'm not sure if Lyme transmits in pregnancy. I'm on the edge, I'm not saying it does happen. I'm not saying it doesn't happen, and, I've actually published a lot of reviews on Lyme in pregnancy, and there have been textbooks with chapters on Lyme in pregnancy, congenital Lyme that magically disappeared, so there's from the medical textbooks, put together by colleagues of mine. So the infectious disease community, which is 10,000 strong, Infectious Disease Society of America, basically Lyme is easy to diagnose, easy to treat. It's not clear whether Lyme transmits in pregnancy. It's not even identified in the pediatric red book, which is the American, kind of book that pediatricians use for every infectious disease. It doesn't even mention congenital Lyme. And when I approached the NIH a few years ago about could we put together an initiative on looking at Lyme in pregnancy, similar to the work I did before in HIV in pregnancy, that was one of my interests, part of my funding that I had when I was working in America. And I worked really closely with the National Institute of Child Health and Development on HIV in pregnancy. I said, could we do the same thing for Lyme in pregnancy? They said, no, it's not even identified as a possibility in the pediatric red book. So we're challenged, as far as that goes. So my approach is I see patients. Guidelines are guidelines, there's nothing in those guidelines that say I can't treat people for longer. Most of my colleagues in the closet treat people with Lyme for longer. They just don't have the guts, to say they're doing it. There's lots of data coming out now from private funding that, that Lyme persists, that even 6 months of IV antibiotics in some situation doesn't eradicate the spirochete. But the Irish guidelines say 10 days of doxycycline and you're better. And I can give you case after case after case, where patients come in and say, oh, this doctor, I went to the infectious disease doctor, and they said to me, you've had your 10 days of antibiotics. We can't give you any more. The infection's gone. And when they say, but I got better the 10 days of antibiotics, when I stopped the antibiotics, I got worse. I can teach my labradoodle that, oh, the antibiotics were doing something. Antibiotics work against bacteria. So, and if you got worse after stopping the antibiotic, if it's any other infection, any sensible doctor, and my labradoodle as well, would say, oh, you need a longer course of antibiotics. But with Lyme disease, no, you've had your course of treatment, the infection's gone, we can't give you any more treatment. I don't practice medicine that way. And I feel quite comfortable doing that, to be perfectly honest, because this is the way you practice infectious diseases for every other disease area except for Lyme disease. And it's a paradigm, it's a paradox, it's a puzzle. But I treat patients, not guidelines. And I stand by that.
So Dr. Lambert, we've had a lot of people come on this podcast and not only talk to us about Lyme does persist, right? In research studies, Dr. Alan McDonald did a few, he came on. We've had a lot of other researchers on that have done these studies to show Lyme persists after prolonged extended antibiotic treatment, even, never mind short-term antibiotic treatment. So it sounds like the first barrier we're having here is this: most people believe a short course of antibiotics will cure Lyme disease. But I think the second barrier we're looking at here is, will a long-term treatment of antibiotics cure Lyme? And we've had people come on and argue the answer is no, because when we use antibiotics, the spirochete will kind of shrink up into a cyst form, which doesn't get addressed by antibiotics. And when the antibiotics are no longer being introduced into the body, it unravels again back into a spirochete. What are your thoughts on that? Do you think that beyond the length of treatment with antibiotics, that the bacteria is smart enough to kind of avoid antibiotic treatment and then change, like many people say that are out there in the Lyme community? Or do you think that's just a false rumor?
Well, I don't think it's necessarily a false rumor, but you actually have to kind of look at other disease areas. If so I treat all infectious diseases. So if I treat tuberculosis is an intracellular organism. You need to treat with 4 antibiotics for a minimum of 6 months, and sometimes 12 months, and sometimes 18 months. And if you don't use rifampicin, which is a really good antibiotic to penetrate deep intracellular into the tissues to kill off the tuberculosis germs intracellular, you can't go 6 months, you have to go 18 months. So there's all sorts of guidelines for treatment of other intracellular organisms, with longer courses of antibiotics. And there's all sorts of theories that, doxycycline is driving the infection. It's knocking down the infection, but isn't eradicating the infection. I guess we don't know because we haven't done studies. So I've got lots of theories, so I've got lots of theories that if somebody shows up a year after a missed Lyme diagnosis, it's much more difficult to treat than if they show up 3 days after being bitten with a bullseye rash with aches and pains all over. And that's no different to another infection that I occasionally treat. Farmers get an infection called Q fever. And Q fever is caused by a bacteria that comes through the lungs. And if you catch it within the first month or two, 4 weeks of doxycycline, Bob your uncle, you're cured. But sometimes you just get a transient infection of the lung, and then it disseminates into the body, it disseminates into the bone marrow, it disseminates into tissues of the body, the liver. A year later, you show up with your diagnosed Q fever. It's 18 months of doxycycline and hydroxychloroquine to cure people. So we have, for other infections, we've got a definition of early treatment, early diagnosis versus longer term treatment. But it does, if you've got Lyme for 5 years and somebody finally diagnoses you, in Ireland, it's 10 days of antibiotics. If you're caught within 2 days, it's 10 days of antibiotics. There's no differentiation of, the duration of the infection. And if the infection's longer, like I said, I think it's still potentially curable. And people talk about going into remission. I just think that you never really cured it. You never really eradicated the infection. And why is that? We don't 100% know, but I can give you another analogy. Back in the olden days, when we used to treat people with HIV and AIDS, there was no treatment. So regardless of what you do, their immune system, their lymphocytes get lower and lower and lower, and then they finally get AIDS. And they developed all these infections, and they developed reactivation of infections. And then when I treated them for these infections, they got better. And when you stop the antibiotics or antivirals or antifungals, the infection came back again because they didn't have an immune system to work in combination with the antibiotics to clear the infection. So the thing that clears the infection is not just the antibiotics, in my opinion, it's repairing the immune system, especially people with more long-standing infection, and I think that's critically important. So the 3 I's, infection, inflammation, damaged immune system, you have to address that. And then the interesting story from HIV is once we get treatments for HIV, the antivirals, people's immune system, their lymphocytes went back to normal. Their lymphocytes, the T helper cells started working, and then next time you treated that infection, the infection went away and it stayed away because you treated with the right anti-infective and their immune system was working in combination with the anti-infectives and they cleared the infection. And I think that really is a challenge with quote unquote chronic Lyme, is it's more than just the infection, it's repairing the immune system. You have to do more than just treat with antibiotics. And that's what I used to do 10 years ago, when I first saw patients with even chronic Lyme. I just started treating them with antibiotics and they got better. And when I stopped the antibiotics, they got worse. It wasn't until I started adding in things to repair the immune system, I started adding in things like LDN, low dose naltrexone, which was actually used back in the day of HIV and AIDS, before there was treatment for HIV and AIDS. It had anti-inflammatory effect, immune modulating effect. It gave people with HIV, there's placebo-controlled trials in LDN. So when I see people with early Lyme, I just treat them with antibiotics. But when I treat people, and usually that does the job. And how long do I treat them? I treat them as long as it takes till their symptoms go away. And that sometimes that's just a month. Sometimes it's 2 months. Sometimes it's 3 months. But if I see somebody that's been infected for years and years, I really don't just treat for the infection or infections. I also do things to target the inflammation, do things to target the immune system as well.
So it's interesting because it seems like, and here in the States, this is not commonplace at all with infectious disease doctors, but many people who have this podcast will have late stage Lyme disease, right? At that point, it's probably further disseminated into the body because you've had it for so long and you're probably immune compromised from the infection. So if your argument, which, I think most people that have come on this podcast agree with, most experts and leaders in this field, that the immune system has to be addressed as well. Otherwise, antibiotics are a Band-Aid, right? The antibiotics will give you temporary relief. And when you go off of them, you may get sick again because your immune system is not functioning the way it should to help you eradicate the bacteria. Why aren't we considering using immune modulation or immune supportive, either drugs or herbs or low-dose naltrexone, et cetera, as more commonplace to supplement antibiotic treatment to get a larger percentage of people with late-stage Lyme better?
Well, you're asking the wrong question. I'm doing that. I don't know why other people aren't doing it. You know, very simply that, you know, you kind of learn from experience, you know, if you treat people and they get better, and if you stop the treatment, they get worse. You either need to treat them longer, or you need to kind of do something more than you're currently doing. And when I see people with longer, I can give you a few examples. When I see people with chronic Lyme, some of them have lymphocytes, T lymphocytes that are 200, 300, similar, back in the olden days, if your T lymphocytes, T helper cells were less than 200, that gave you the diagnosis of AIDS, and then you were prone to catching all the opportunistic complications, CMV reactivation, zoster, all the viral reactivation, fungal reactivation, bacterial reactivation. So I've just kind of developed my own protocol based on, working in this area. And I always tell patients, I think you can cure Lyme, but sometimes all the antibiotics are doing is stunning the infection, not eradicating the infection. And what you want is not a stun gun approach. You want the Uzi approach. You want to kind of kill them off, not just stun them. And I think in some situations, antibiotics alone are just knocking them down, but not eradicating. So we're kind of agreeing on this. But like you said, you can't do a study on this stuff because there's no funding, because in the medical community, there's still no acknowledgement that there's chronic Lyme.
How would you define chronic Lyme? I'm sorry to interrupt, Dr. Lambert. How would you define chronic Lyme, right? Because we hear about acute Lyme disease, chronic Lyme disease. How do you just give us your definition of those two terms, acute Lyme and chronic Lyme?
Right. Well, look, any infectious disease, let's look at other infectious diseases. If you get hepatitis B and you haven't cleared it by 6 months, 90% of people that get hepatitis B clear it. 10% are chronically infected. If you have hepatitis B DNA positive after 6 months, it's chronic. Same thing with hepatitis C. So I'm not sure that definition has been made, but that's my definition. My definition of chronic Lyme is you've got it for 6 months and you still have symptoms, that to me is chronic Lyme,
that's actually a very clear definition, and I think that makes a lot of sense. So thank you. And I do want to ask, because there's some conflicting information, or maybe it's a lack of understanding on my part when it comes to the immune system and Lyme disease, right? So we understand that Lyme will compromise or weaken your immune system. And you mentioned that the immune system is so weak, it's comparable to somebody with HIV because it's so weakened and not doing what it needs to do. But then we hear a lot of people tell us that they have autoimmune diseases from Lyme, or Lyme can mimic autoimmune diseases. And I understand that to be an overactive immune system attacking healthy cells in the body. So it seems like that's not really in line, where in one scenario, we're saying it basically obliterates your immune system where it doesn't work. And then we're saying in another area, well, it's causing your immune system to overreact and attack healthy cells in your body. So can you help us clear that up? And if I misstated anything, correct me there.
Yeah, well, I don't think it's that simple. It's not that simple. It's like when people with HIV and AIDS, before they died, their lymphocytes got lower and lower and lower. Lymphocytes help you fight infection. Lymphocytes help you clear infection. And T helper cells orchestrate your immune system. They control B cells. They control antibody production. They control your immunoglobulins. So I would say you have a dysfunctional immune system rather than a weak immune system, okay? So that's it. So you have a dysfunctional immune system. In some situations, it's overactive. Sometimes it's underactive. Sometimes your immunoglobulins are low. Sometimes your immunoglobulins are high. But it's dysfunctional. And if you look at everybody with HIV and AIDS, they often have a high gamma globulin level in the body, but they're making antibodies that are dysfunctional antibodies. They don't work well. They have polyclonal. If you'll do what's called an electrophoresis of their and look at their immunoglobulins are all over the place. So they're making antibodies, but they're not making good antibodies. So they have a dysfunctional immune system. I'm just using kind of analogies for other diseases to kind of apply it to Lyme, my understanding. But like I said, an awful lot of it is theoretical. And you get release of these there's a lot of, when you get destruction of these cells and stuff, you get release of all these chemokines, cytokines, IL-2, IL-6, there's all these different, tumor necrosis factors. So you're getting release of all these, inflammatory cytokines, kind of, things that are released that cause inflammation. So I, like I said, I still stand by the fact the longer the disease is in your body, the more damage it does to the immune system. And like I said, there's clear analogies with COVID now. When you get long COVID, you have the same kind of processes going on. You have your lymphocytes go down, your lymphocytes become dysfunctional, you get the development of autoantibodies, you get all sorts of inflammation in the body. And we've learned more, I think, I've learned more about Lyme disease, chronic Lyme disease, from working the last 3 years in long COVID, because there's millions, if not billions, been put in publications on long COVID. And I think there's an awful lot of similarities in terms of the symptoms and the brain damage and the autoimmunity and the immune dysregulation and the inflammation that goes on in both diseases.
And I think it goes back to the 3 I's of what make people sick that you talked about earlier: the infection, the inflammation, and the immune dysfunction. If the immune dysfunction results in inflammation because of the cytokines, it perpetuates a cycle. And if you don't address the immune system, which is causing inflammation, and you only treat the infection, we're reducing our odds of success in treating patients, right? So this is coming back to what you said earlier. I'd like to ask you, though, Dr. Lambert, to respond to something, because we posted something recently in the last week or two about a comment by Judy Mikovits, and she made a claim, and it caused a lot of anger in the Lyme community. But she basically said there's no such thing as Lyme disease. It was and always is HIV/AIDS. And it seems like such a radical statement. But can you respond to that comment? I'm not sure if you're familiar with it, if you've read up on any of this in the last couple of weeks.
No, I haven't. I haven't at all. I haven't read any of this stuff, but it just seems a bit absurd, But I've had infectious disease doctors in Ireland come to me and say, oh, even when patients were antibody positive for Lyme, when there was a history of a tick bite, and they'd given the 3 weeks of antibiotics and didn't get them better, and I treated them for longer, they said, it's not Lyme disease, it's probably some mystery retrovirus that they have. And my response to that is that, yeah, retroviruses respond to antibiotics, don't they? No, they don't. Retrovirus responds to antivirals. But there's huge there's huge anti-science in the infectious disease community, and a huge unwillingness to actually look at the complexities of Lyme disease. So this is what you're dealing with. I just think it's a bit of a puzzle. I'm on the editorial board of a number of journals now, and it's almost impossible to get published, because if you try to publish something in chronic Lyme, you get an Infectious Disease Society of America reviewer who shoots down your submitted manuscript, basically saying there is no such thing as chronic Lyme. When I try to get, I've got grants from HIV, from hepatitis, from COVID-19, from long COVID. I've successfully, as an I do bench to bedside. That's kind of, I'm a clinician, but I see myself as an academic clinician. I try to get funding for Lyme disease, tick-borne infections. I submitted a grant to the European Union. And it was the 3 I's: infection, inflammation, autoimmunity. And part of the study was actually to go internationally to look at tick-borne infections in Belize, because I've done training courses in the Caribbean and Central America on sexual health, and I know the Minister of Health, and my son's godmother was PAHO director for Belize, so I had good connections. And the plan was to look at the tick-borne infections in Belize, and I get well reviewed by 4 of the reviewers. Reviewer number 5 basically tore apart my application, including comments like, I have a delusional misunderstanding of the epidemiology of tick-borne infections in Central America. there's no evidence that there are ticks in Belize, and even if there were, there's no evidence that they bite humans. So this is, you know, I mean, seriously, this was the reviewer. So, I mean, I get such a bad review, it sabotaged my grant, it was rejected, and I couldn't even reapply the following year. And interestingly, my colleague in the Caribbean, you know, in Belize, the Minister of Health, was hosting a group of scientists from America, from the University of Notre Dame and Mayo, to discuss tick-borne infections in Belize. And there's the Mayan ruins in Belize, there's about 10 of them. One of them is called Cajopec. And Cajopec in Mayan means field of ticks. So 2,000 years, the Mayans knew that there were ticks in that area, but my grant was sabotaged. And when I actually tried to contest it and find out who the reviewer was, it was total cover up. They wouldn't give me the name of the person. So there's a huge bias in the medical community and in the scientific community against Lyme disease. I'm just giving you my experience, you know, with me applying for grants. I won't even apply for grants anymore because it's a waste of time to spend all this time and effort putting a grant together and then getting a reviewer telling me I've got a delusional misunderstanding of the epidemiology of tick-borne infections in Central America and having my grant sabotaged. The same thing happens time and time again, I think, for a lot of publications that people try. I can give you example after example. I've had to override negative comments from reviewers who tried to sabotage publications on chronic Lyme, you know, over the last year or two. It's a puzzle to me, because I think we should be excited about new science, about learning new diseases. You know, the patients are always right. There's something wrong with them. We should be supportive of patients. That's why we went into medicine. But when it comes to Lyme disease, you know, GPs and infectious disease clinicians, as a rule, kind of grow horns, and they close the door on the patients, and they close the door on the science.
And it's really frustrating, but we still applaud your desire and your hard work to get these publications studied. You mentioned you have 25 just in COVID alone, and you know, a ton of others, it sounds like. And you're still looking for better testing to be able to prove people have Lyme disease, and possibly that it's still there after treatment, to have these definitive markers to prove things and not have anecdotal, you know, suggestions about Lyme disease. So ironically, there's a lot of things over the last week that have brought us back to you, even though we had this interview on Friday. We had somebody reach out to us on social media asking us about TLAB. So we started doing a little research on TLAB, haven't heard of them before. And of course, we found your Lyme group, the Lyme Resource Center, posted a YouTube video with the founder of TLAB, Dr. Robert Mazzaiani, or Mazzaiani, I believe is his name.
Mm-hmm.
So can you just give us a little background about what your work is through the Lyme Resource Center and how that led you to do this YouTube video with Dr. Robert with TLABs?
Good. Well, actually, I just established what's called the Lyme Resource Center, is basically a charity to really focus on education and training and prevention. And I actually planned on setting it up in Ireland. And when I tried to do that, the infectious disease doctors of Ireland en masse came against me and prevented me from doing it. You know, it actually, there was a hearing at the Oireachtas, which is the Irish Senate, you know, the government Senate. And I actually presented to that group on behalf of TikTok Ireland, the Irish charity, and the Department of Health and the infectious disease doctors in Ireland came basically to sabotage me without my knowledge. So that's 2018. So a bit scary to be, you know, it's all on YouTube video. It was recorded on RTE, which is the Irish kind of public television. So it was all kind of totally ambushed when I did that. So I actually set up the Lyme Resource Center in Scotland, and we've done a number of GP trainings, and I run a conference every year in Dublin called the Crypto Conference. And the Crypto Conference was actually the brainchild of a doctor in France called Christian Perron. And Christian basically was basically fired from his job for standing up for Lyme disease and standing up for long COVID and COVID. But nonetheless, he's kind of a very talented guy. And we've ran 3 conferences in Dublin, and we brought together scientists from all over the world. And one of them was Mosanyemi. And Mosanyemi was a previous president of ILADS, and he's actually quite interested in Bartonella. And his opinion is Bartonella is probably even more, common than Lyme disease, because if you look at the symptoms of Lyme disease and the symptoms of Bartonella, they're very similar. And actually, when I treat people for Lyme disease, chronic, I treat them for Lyme, but I treat them with combination antibiotics that cover Bartonella as well, because the challenge is it's quite hard to diagnose. But anyway, Mosanyemi's worked with the University of North Carolina, the vet school, and they actually have, the vets are really good at treating Bartonella. The vets are really good at treating Babesia. The vets are very good at treating, Borrelia, all these infections, and they have PCRs available. So Mosanyemi's worked in collaboration with the vet school and University, I think North Carolina State, and I think he's had a spin-off laboratory where he's put together some diagnostics. So I just kind of work with him kind of collaboratively. And that presentation was just one of the presentations that he gave at the crypto conference that was held this spring in Dublin, Ireland,
So that's interesting because Ed Breitschwert is from the University of North Carolina as well. We've had him on the podcast, and he branched off to form Galaxy Diagnostics, and we talked all about that. So it sounds like this is somebody else out of University of North Carolina, this Dr. Robert Mazayeni, and he's now forming T-Lab as well to help specialize in tick-borne diseases.
Exactly, and I think Mosanyemi is. I don't think Mosanyemi is I think he's actually, I think, Washington D.C. based actually. So he collaborates with the laboratories in North Carolina. I'm not, I actually don't know the details of, I'm not involved in any commercial way with these guys. I just kind of work, professionally, and they've got some good ideas, and this is not the kind of presentation that would ever be allowed at, the infectious disease meeting in Boston that I'm currently attending. It just wouldn't be there. It wouldn't be there. There needs to be a forum where like-minded scientists can get together to present the information. I'll give you one interesting anecdote, though, is that we've been working on GP training in the UK with a number of GPs, and the UK, Scotland, and England are not happy that we have the proceedings from the crypto conference posted on the Lyme Resource Center.
Wow.
How's that? It's sort of like every level, because it goes against the teachings in the UK. In Scotland, about 6 months ago, they had a conference in northern Scotland called the Northern Tick Conference. For some reason, I wasn't invited to it. I don't know why, because I'm Scottish, and I do clinics actually in Scotland as well, in Dublin. But and I've got this Lyme Resource Centre. We're the only charity in Scotland that is focused on tick-borne infections, and we're the lead trustees. I'm the lead trustee for that. But nonetheless, at that conference, they had a closed meeting. They invited IDSA thinking clinicians from Scandinavia who basically said Lyme is easy to diagnose, easy to treat. 2 weeks of antibiotics, you're cured. There's no evidence that longer course antibiotics work, and indeed, longer course antibiotics is dangerous. See, so by me having a Lyme Resource Center that is putting together scientific presentations that goes against that mantra, I think is threatening to them, to be perfectly honest. We just actually published in Microorganisms Journal, if you look up, there's a recent publication by one of my medical students at UCD, and name is David Z, XI, and it's Microorganisms, and it's longer course antibiotics in a cohort of over 300 patients from Dublin, Ireland. And the data from that basically said about 70% of the patients improved based on questionnaires on longer course antibiotics. And this was, 2 to 4 to 6 months of antibiotics. And of 301 patients, only one patient couldn't tolerate the antibiotics. So I see patients, I follow them longitudinally. The people at the Northern Tick Conference have been told it's dangerous to treat with longer course antibiotics, but I have publications otherwise. But I was not invited to this meeting to present that data. So it really is it's a closed shop. It's really a closed shop, for people who are not following IDSA guidelines. Lyme is easy to diagnose, easy to treat. There's no such thing as chronic Lyme. And a recent a recent submission to a journal that I edit, two of the reviewers just basically blew it out of the water because they talked about chronic Lyme patients' experience, of having to deal with the healthcare system. And the response from the reviewers, they just blew it out of the water, saying there's no such thing as chronic Lyme, even though there was a whole paragraph in the manuscript, showing the new science, showing there's a lot of data coming out on chronic Lyme being isolated. There's private research going on, through the Cohen Foundation in America, at Tulane, at Stanford, at Columbia, at Johns Hopkins. There's a lot of new science coming out, but that science has been totally ignored by, the standard practitioners. So it's an ongoing challenge. So I keep on publishing, but the greatest satisfaction is just taking care of the patients and trying to get them better with the approach that I've developed. But we don't have a standardized approach because there is no recognition that Lyme persists.
And please keep publishing, right? I mean, to your point, we have a lot of people here in the States. We have private and public money being pumped into Lyme disease research because, in the case of the Cohen Foundation, a family member was impacted by chronic Lyme and they pumped a ton of money into it. So the more people that are impacted by chronic Lyme, the more money we're going to have being pumped into research. And I think we're getting somewhere where it's becoming very difficult to ignore these studies coming out of major universities here in the US. So I think, I'm hopeful at least that that's where we're going. But you talked about, Dr. Lambert, being able to treat people and help them get better. Obviously, you talked about a wide variety of antibiotics. You do a combination of antibiotics. You do LDN, which I want to get to in more detail later. But for this question, I want to ask you about Monica Wild. So we've chatted with her a little bit, in the past, and we saw in doing research about you that you've done some videos with her as well. And it looks like you've kind of at least looked at using some herbs. So Monica Wild being an herbalist, right? And you've done some videos with her. Do you use herbs as well to treat your patients in collaboration with Monica Wild?
Well, the thing is a lot of patients with Lyme disease end up going to herbalists before they even come to see me. So sometimes I'll be referred patients from herbalists, who don't suspect Lyme or, and then similarly, what I used to do when I first treated patients, I especially long-standing patients, I treat them with antibiotics, I treat them with some supplements and LDN, and then I'd send them on their way and they'd relapse. And, a lot of Monica studied in America with Buhner, so the Buhner protocol, and, there's a Cowden protocol in America as well. And the reason people went to herbs is because herbs work. But herbs are not as potent, I don't think, as antibiotics. Basically, antibiotics are just concentrated herbs. If you look, so I think there's a role for herbal products in supporting people. For example, there's a number of different supplements that I use that have been put together by Monica that help with the inflammation. So besides LDN, N-acetylcysteine, can help. There's lots of things going on at the cellular level. The probiotics can help because there's lots of things going on at the microbiome. Your immune system is mostly in your gut, not in your blood cells. So I think there's clearly a role for a multidisciplinary team in terms of managing patients with with chronic Lyme. And yes, I do work with the herbalists as well, because sometimes we work together. Sometimes they refer patients to me because their treatments aren't doing the job, and my heavy-duty antibiotics will do a better job of killing off the bacteria. And then sometimes when I've completed treatment, or sometimes even when I told you 2/3 of patients I treat, I think, improve on the treatment, but 1/3 don't. I don't think that means you should give up on them. I think you should continue to work and trying to look at ways to, improve their quality of life, to relieve their symptoms. And I think, herbalists have a role in that. Herbalists were treating patients with, for infections before 1945, before penicillin was discovered by that Scotsman, Alexander Fleming in London at St. Mary's Hospital, So herbalists have been managing infections for centuries. So I think we're all part of the same team.
So on that note of, 1/3 of people don't get better, right? I think that's very consistent with what we're seeing with COVID, where some people get COVID, they get over it and they move on with life. Other people get COVID and they develop long COVID where they have persistent symptoms that are very similar to chronic Lyme symptoms, fatigue, brain fog, potential, depression, things like that, right? And there's this eerie connection, and your work obviously is both in Lyme disease and COVID. So can you share with us what your thoughts are between the overlap of long COVID and chronic Lyme disease?
Well, not exactly, but I'm not really sure I have all the answers. But the challenge is when you see somebody with suspected Lyme disease, you don't know whether there's still active infection or this is post-infectious. You really don't know. And if you look at the Hopkins, Hopkins used the term that 20% of people after treatment don't get better. They call it PTLDS, post-treatment Lyme disease syndrome. But what infectious disease doctors do is they say this is, P stands for post-infectious, like the bacteria is gone. But you don't know if the bacteria is gone. P could stand for persistent infection, so there still could be residual infection. And my opinion is there is residual infection. When I see patients, I don't see everybody with chronic fatigue in the world. I see patients where I suspect there's an underlying bacterial infection driving this. So I try to select my patients. I don't want to have them show up and say, I don't think you have Lyme. I'm not going to give you a course of treatment because I don't think this is helping you. So, but the 2/3 that get better, I think there's an underlying bacterial infection. The 1/3 that don't get better, maybe it's a biofilm. Maybe there's residual bacterial infection there. Maybe the bacteria is burned out. Maybe the symptoms are being caused by reactivation of viruses, And that's what happens with long COVID. With COVID, the virus is gone. But the immune system's been damaged, and everybody has in their body viruses. You have herpes viruses, HSV1, HSV2, HHV6, human herpes virus 6, VZVs, the zoster virus, which is a herpes virus. People have Epstein-Barr virus, which is another herpes virus. People have CMV, which is another herpes virus. And we actually published this. One of my other doctors, we just published this in the last year. And we looked at the first wave of COVID, patients who ended up in the ICU, people who ended up in the CCU at my hospital. And about 10% of them got reactivated during the time that they were critically unwell in the high dependency unit or intubated in the ICU. 10% of them were getting reactivation of herpes, which is scarily similar to back in the day of HIV and AIDS. When people ended up in the ICU with HIV and AIDS, they were getting recurrent outbreaks of shingles, they were getting outbreaks of perianal herpes, they were getting oral herpes, all this kind of stuff. But also, the ICU did PCR for CMV, PCR for Epstein-Barr virus, and some of these people with COVID were getting reactivation of EBV and CMV in the setting of acute COVID, and their lymphocytes were low, which is the critical part. When your lymphocytes go low, you get immune dysregulation and you can get reactivation of viruses. So I think there's a possibility that some of the patients that come to me with Lyme disease, maybe there's bacterial infections that we're not hitting with the antibiotics, or the second possibility, they're just so immunocompromised, they're getting reactivation of all these endogenous viruses. And some of their symptoms may be caused by that as well. But we really don't know because we don't have the diagnostics, or we don't have the studies to prove that. It's all theoretical.
But it sounds like you would email us the presentation you're giving next month. And in your presentation, you did a study And you started this, I think, in May of 2022, early COVID days. And you found, like you noted, reactivated Epstein-Barr virus, many, herpes viruses, the cytomegalovirus, right? All these opportunistic viruses that are active in people with long COVID, likely due to immune dysregulation, as we noted in Lyme disease. So if you're publishing studies about this in long COVID, and we see this in chronic Lyme disease, I think that's where the potential overlap is in the subset of chronic persistent patients is immune dysfunction and reactivated viruses. Would you agree that that's kind of where we're going for a subset of the people?
I agree. I think that's where we're going, but show me the publications from all the Lyme literate physicians.
Right.
There aren't.
None.
And they stand up and they say, and you go to the IDSA presentations and they say, we do all these tests, and this test, so patients order tests, and they're positive for EBV, and they're positive for CMV, and they're positive for HHV8, and they're positive for Coxsackie viruses, and they're told these viruses are causing your symptoms. But we don't know because they're antibody tests.
Right.
I suspect they might be, but we need PCR tests. We need virus-specific tests to really prove that point. So we kind of preach that to patients, but we don't have the proof. I've looked at the literature on long COVID, lots of money, lots of research have gone into that. We've got the proof that that's part of what's happening with long COVID. I suspect that's the same kind of thing that's happening with, patients with chronic Lyme. Additionally, I think the presentation I sent you, that if you look at the PET scans of patients with long COVID and the PET scans of patients with chronic Lyme, there's the same, very similar abnormalities in the brain. There's hypoperfusion defects in part of the brain that are signaling a lot of the same symptoms, the dysautonomia, the pain, the respiratory centers, or, the cerebellum, the balance centers, the parts of the brain that are affected in chronic Lyme based on PET scan studies are very similar to the abnormalities you find in long COVID.
Just to put, with your research in COVID, obviously we believe that Lyme can persist in many people, likely. And also we know that the immune compromised state leads to reactivation of viruses, and that can cause illness as well. I also think we agree that it could be a persistent infection which results in immune dysfunction, causing reactivation of viruses while you still have an active infection that persisted of Lyme disease. Do you think that's true in the COVID world as well, that the actual viral infection persists and also at the same time results in immune dysfunction, causing even more reactivated viruses that were previously managed by your immune system?
I was at a presentation today, and immunocompromised patients, there's patients who are, bone marrow transplant patients who are persistently positive for COVID, both by PCR and culture, 45 days down the way. I don't think, as a rule, looking at most of the studies, is that patients still have reservoirs of COVID in their body. We might be wrong, but I think our understanding of the coronavirus is they die out. So it's a post-infectious inflammatory autoimmune condition. And with Lyme disease, I treat long COVID and chronic Lyme the same way, except I don't use antibiotics. But then every now and then you will get patients with long COVID whose immune system gets so low that they are getting, I think, probably reactivation of subclinical bacterial infections, whether it's Lyme disease, whether it's Bartonella, whether it's Mycoplasma, chlamydia, some of these intracellular pathogens. We hypothesize that this is what could be happening. We've got lots of resources to prove it with long COVID. We've got no resources to prove it with long Lyme. And this is a frustration, I think.
So let's talk about how you do treat people, because you talked about with Lyme disease, again, it's a combination of antibiotics. You do certain supplements like, to help the immune system and allow a detox. I think you were kind of talking about some of those supplements. Potentially you integrate an herbalist and some herbal treatment as well, or you can refer them out after the fact, or they get referred to you. And then the key here was also you talked about that you really like to use low-dose naltrexone, right? And when people Google that, it gets kind of scary, because it's like if you have an opioid addiction, you take naltrexone to block the opioid receptor so you can't get a high, I believe. Is that correct from certain drugs?
No. If you I work in inner city Dublin, so I take care of drug overdoses all the time. I work in the emergency room, and I see people not breathing because they've overdosed, and you give them injection of naloxone 50 milligrams, and it's not a narcotic, it's an anti-narcotic. So it blocks the opiate receptors. And all of a sudden you wake up, you start breathing again, you're not in coma anymore. So naltrexone 50 milligrams is used as an antidote of people who overdose on narcotic medications. And like I said, there's a lot of studies that have come out going back to the 1980s of using low dose naltrexone. So it's kind of an off-license indication, and it has some kind of anti-inflammatory effect. It has some kind of immune modulating effect. And it was used placebo-controlled trials in the early days of HIV and AIDS, and it improved people's quality of life. It helped the brain inflammation that everybody with HIV and AIDS died of. I think it helped repair the lymphocytes, so the lymphocytes were less dysfunctional. Better to do that than to give them an IV morphine drip and let them die. At least they'd have a quality of life. Subsequently, their studies have been done with LDN, with rheumatologists, with neurologists. So their studies placebo-controlled trials looking at people with atypical MS. And when they actually did brain scans, if you do brain scans of people with MS-like lesions, they've got these little white spots in the brain, T2 weighted, signals in the MRIs and this and that. And when you gave them LDN, 6 months later, the white spots disappeared and the funny neurology they had improved. GI specialists use it for Crohn's disease because they don't need to use the same amount of immunosuppression if they use LDN. LDN has some immunomodulating effect. So LDN's been used for 20 years for other disease areas. And 3 years ago, when I was managing patients with COVID at my hospital, we are the National Isolation Unit of Ireland. I was the director of the National Isolation Unit from 2010, 2018. So any Ebola-like illness will come to our hospital. When the first COVID cases came to Ireland in March 2020, we admitted them and then our staff ended up in the ICU because they became infected. So I established a long COVID clinic to manage mostly the staff from my hospital. And we probably saw about 800, 900 patients with long COVID along the way. And I just followed them every 3 months thinking they were going to get better. And they didn't get better. And I knew LDN worked for Lyme patients, anti-inflammatory effect, immune modulating effects. So I started using it in just some of the staff that I was working with coming to the long COVID clinics, and it appeared to be helping them. So then I did a pilot study that's published. We actually published it. It's the only published study, I think, on any therapeutic for long COVID in the world. And we took a cohort of 60 patients, did a questionnaire before and after start COVID patients. And they'd be people sick for an average of 333 days. And with 2 months of starting the LDN, the brain fog got better, the concentration got better, the generalized pain get better, the headache get better, the mood get better, the sleep disturbances get better. So it has some kind of anti-inflammatory effect. So we did a pilot on LDN for long COVID. And that there's going to be big placebo-controlled trials done in the future for long COVID, but some patients have been sick for 3 years with long COVID now, and it's a very safe product. LDN is a very safe product. The worst thing it does for some people, it sometimes gives people funny dreams. It usually improves their sleep, but sometimes it can give people psychedelic dreams, three-dimensional dreams and this and that. But the side effects are minimal. And I would say about 80% of patients with long COVID benefit from LDN over a period of 2 to 4 to 6 months. And so I think it's my clinical observation is it helps long COVID patients. My clinical observation, it helps chronic Lyme patients because it's working on the two other eyes. The antibiotics working on the infection, LDN's working on the other two eyes, and it helps most patients. And it's a very safe option. Like I say, it's like taking Smarties. It's very safe, and you can take it for years and years.
So I just want to circle back to one question before Rich picks it up, and that is, you talked about your crypto conference, and I know I'm kind of going back here, but why did you name your conference crypto conference for, infectious disease and Lyme disease? Seems like an interesting name. I'm curious the genesis of where that came from.
It was a French thing, so it wasn't my. I actually don't like the term personally, but it was the brainchild of doing the crypto conference came from Christian Perron in Paris, and it's looking at cryptic infections. Cryptic infections are hidden infections, So crypt is a term that's used to describe hidden infections. So I think, it's an occult infection, Most patients with Lyme disease, like I said, I think we miss 85% of the cases. 15% of people remember the tick, less than 50%, maybe 30% get the rash. The antibody test is only positive in 50% of occasions. So Lyme disease, diagnosed late, is a cryptic infection. It's an occult infection. It's a hidden infection. So that is the genesis of the word crypto infection. It's kind of it was a French, orchestrated title that I fought to change with Christian Perron. But since it was his idea to do the conference originally, we stuck with it.
So, Dr. Lambert, can you talk with us about some of the other tools that folks in the community may want to consider using when dealing with infections, dealing with inflammation and immune dysfunction, other than antibiotics and low dose naltrexone?
Yeah, well, so NAC, N-acetyl, a lot of patients with long COVID get what I call kind of the PEM, the post-exertional malaise, mitochondrial crashing. So I think you need to, part of the solution is repairing the mitochondria. So using glutathione can be helpful. I tend to use NAC, N-acetylcysteine. So NAC is converted to glutathione, and N-acetyl has antioxidant, has liver protection values. So I see NAC as part of the solution as well. And I use that for both long COVID and for chronic Lyme. I mentioned the microbiome. There's studies been done, so if you're on combination antibiotics, you should be on probiotics. There's a yogurt drink called kefir that people commonly take. So it's protecting the gut, but also kefir is a yogurt drink that Eastern Europeans use for chronic fatigue syndrome, used for fibromyalgia. If you manipulate your gut, you change the microbiome. And that's critically important, So I think, doing things to dietary changes can be important as well. I'm not a dietitian, so I say take a probiotic or take kefir as part of the solution. Anti-inflammatories, patients with Lyme have headaches that are unrelieved by pain medications. They have joint pain that's unrelieved by narcotic pain medicines. I recommend they take turmeric with black pepper, natural anti-inflammatories. Seems to help, So there's like I said, I don't have a set recipe for any patient. One of my patients gave me a book on Arctic root, on Rhodolia rosea, which is a herbal product that Russian doctors prescribe for brain, for concentration, So if you do your homework, you find out that, I found patients benefit from those kind of products. For sleep in Ireland, they give people with sleep disturbances, with Lyme disease of sleep disturbances, people with long COVID of sleep disturbances, you give them, some of the the addictive sleeping medicines. It dopes them up for days on end. I preferentially use melatonin. Melatonin, is used for, kids with behavioral problems. It's used for patients with brain injuries, It helps regulate their sleep pattern. I call it a sleep hormone rather than a sleeping pill. It's not addicting. It's a very safe thing to take. So I don't have one recipe. I individualize my treatment, but you have to address, diet, you have to address sleep, you have to address the mitochondria, you have to address inflammation, you have to address the immune system. And then, You have to kill the bacteria, as opposed to stun the bacteria. And as an infectious disease doctor, I kind of have I don't have a set recipe of what antibiotics I use, but I use different antibiotics, including antibiotics that have good penetration intracellular, drugs like azithromycin, drugs like rifampicin, in combination with the standard antibiotics. But like I said, I don't have a set recipe. It's not like a Chinese menu, one of A and one of B and one of C, which some actually private clinics have. I try to individualize care based on what patients will tolerate and what symptoms they have.
Dr. Lambert, it always scares me when we interview folks who essentially have a recipe type approach. And the reason that always makes me anxious is because we're going to have a different combination of microbes. We talked about this earlier, that are going to be spit into you by one or more tick bites. We're going to have a different combination of microbes that our body has already been harboring. And when you're putting those two things together, you're just never going to have the same footprint in any individualized person who is sick with Lyme disease. So, if you walk into this with a recipe, I think that's, to use the term, it's a recipe for disaster.
Right. No, absolutely. And like even antivirals, as a rule, I don't use antivirals because the best, I think that the underlying problem is a bacterial infection as a rule. Now, sometimes you can get reactivation of viruses. Right. How do you manage that? Repair the immune system. If you have a transplant patient who's getting reactivation of CMV or reactivation of the herpes viruses, you drop their immunosuppression so that they don't reject their transplant, but they're not severely immunosuppressed. You stop, if somebody gets COVID and they're a transplant patient, you cut back on the transplant medications so that they can recover from COVID. So I try not to treat viruses. But sometimes if you've got somebody who's got recurrent shingles all the time, despite, being treated, I sometimes put them on antiviral suppression, understanding that you're never going to cure the shingles, but at least if you suppress the shingles, that gives them time to take all the other supplements to repair the immune system. So it gives their body some time to recover. So like I said, I don't have a set recipe. I just have an approach.
I appreciate that. And I love that approach. So can we talk about the relationship between treating infection, treating inflammation, and treating immune dysfunction? Because one of the things that we're always anxious about on this podcast is the impact that the use of long-term antibiotics is having on the immune system, specifically the impact that it's having on your gut. Now, you had shared earlier that 70% of the immune system, or a large percent of the immune system, is in the gut. And when we're taking antibiotics, especially long-term, we are altering, we're altering the gut biome and therefore altering our immune, our immune system. So how do we strike that balance between infection control and immunosuppression from having the use of antibiotics long-term?
Well, I tend to downplay that. I use the example of tuberculosis. Patients in India, there are 2.5 million cases of tuberculosis a year. If they don't take 4 antibiotics for 6 to 12 months, they die. They never say, "Oh, doctor, should I really take those antibiotics because they're going to damage my immune system?" They say, "Thank you, doctor, for saving my life." So, sure. So anyway, so I'm just saying that's one perspective, 4 antibiotics for 1 year, 2.5 million people, that they do that because it's necessary. So you have to do things to protect your gut, along the way. And I actually just saw a presentation recently on long COVID. Patients with COVID and long COVID, the microbiome, their gut flora is destroyed, and maybe that's part of the problem with long COVID. Maybe it's not just the immune system in the bloodstream, it's the gut immunity that's a problem as well. So you have to protect the gut. But when you stop those antibiotics, your gut goes back to normal if you replenish the normal gut bacteria. you get overgrowth of candida if you take antibiotics. I put people, especially women who are prone to thrush, I put them on once weekly antifungals, because otherwise they get mucocutaneous candidiasis, So you have to kind of, so I would say antibiotics kill bacteria. That's number one priority, and you do what you can to limit the damage, you take rifampicin, it can cause liver damage. How often does that happen? In thousands of people I've treated, I've had to stop rifampicin about maybe 10 times out of 2,000. So it's a rare phenomena, but you have to monitor bloods to make sure there's no toxicities. I used to say 1 in 100 people get side effects from the antibiotics, kidney problems or liver problems or, blood count problems. I would say it's 1 in 500. It's rare. It's quite rare. If you monitor the bloods and you change things around. So yes, so antibiotics kill bacteria. It can affect, antibiotics don't attack your generalized immune system, but they do affect the gut microbiome, and you have to do everything you can to keep the gut microbiome healthy. And I've given you my recipe: probiotics, kefir, those kind of products, and a healthy diet.
Now, one of the things that we really enjoyed about doing our research on you before the podcast, and of course you built this out during the course of the podcast, is that you like to work with herbalists, right? You take this approach where you have many different disciplines coming together and working with the patient. And I'm just wondering, when you sort of step down the antibiotics, which you argue is a more aggressive form of killing the bacteria, and when you begin to introduce the herbal treatments, which are not as aggressive in your view at treating the bacteria, but can be effective tools when the bacteria is better managed, which would then have, in most cases, a less severe impact on the gut and the immune system.
Right. No, absolutely. And I think, like I said, before 1945, herbalists treated infections. And if you look at products like artemisinin, which is activity against Lyme, the pharmaceutical companies take the plant, purify it, and turn it into artemisumate, which is one of the mainstays of the treatment of malaria. So concentrated plants are used by pharmaceutical companies all the time. So I think that even when I treat people who have been, my thinking is sometimes when I treat people for a year with antibiotics, if they've been sick for 10 years, I'm not sure I've 100% eradicated every bacteria that is pathogenic in their body. So I think transitioning to a herbalist makes perfect sense, because some of the herbal products, cryptolapsus, which is another product, artemisinin, resveratrol, Japanese knotweed, they have broad spectrum activity, not just against Lyme, but against the polymicrobial infections. And actually you can treat with one herbal product, you can treat multiple different infections if those infections are still there. And I used to just stop antibiotics, and I would say 10-20% of people would come back in a period of 6 months, haven't gone backwards. And I think that happens much less now especially with longer standing infections, when I discharge people from my treatment regime, I turn them over to the herbalists, and I stay in touch with them through the herbalists. Then sometimes the herbal products fail and they have to come back for another course of antibiotics. And sometimes they're 80% better, and over a year of working with a herbalist, they improve to 90% or higher, and eventually come off all the herbs and the LDN as well. So I think I think it's important to understand that, as a medical doctor, we don't have all the answers. And some of the other, professions that we work with have really important contributions to make as well. And I think herbalists are part of that team.
So one of the things we've looked at is the pattern of many of the successful people who are managing Lyme disease, and we've actually called this pattern the PARM pattern, where there are people who go through a process of prehabilitation, where they're getting themselves ready and they're getting their bodies ready through a number of different tools, including detoxification tools. Then they go through this phase where they are aggressively killing the microbes, and then because of so many of the changes that occur in the body, even at a genetic or an epigenetic level, and on a neurological level, that they have to go through a phase of rehabilitation. And then finally, there's sort of a maintenance phase. So what would your reaction be to an approach where people are first preparing for the kill, then going through the kill phase, then going through a rehabilitation phase, and then a maintenance phase, as an approach to treating chronic Lyme disease?
Well, by the time patients come to see me, they've kind of gone very often. They've gone many different places before. So when they come to me, they want to start treatment right away. Most of them want to start right away because they're just tired of being disbelieved or being sick, and this and that. It's had a huge impact in their life. And I always say half the patients that come to me have psychiatric problems because they get neuroinflammation. The other half have psychiatric problems from being disbelieved or treated badly by the healthcare system, so that most of them are, want to go on treatment, but some of them actually say, I don't want to go on antibiotics. I don't, because they'll hurt my immune system. They'll destroy my gut flora. I'm not going to force people to go on antibiotics. I still step back to the point that the best way to kill a bacteria is with antibiotics, not pray like the Christian scientists in Boston do. Antibiotics have the role, and it's the best way to go. But some people don't want to go the antibiotics route right now. So I'm quite happy to say, okay, well, let's focus on the other two parts of the disease, and then maybe start off working with a herbalist, So I think you just have to engage patients, and work with them to come up with a solution. So, I have patients that want to go off on holiday and say, well, I don't want to start the treatment now in case I have side effects. I say, well, start on the LDN, start in the supplements, and come back in 3 months, and we'll start the antibiotics then. So I think you have to negotiate with patients in terms of what the best strategy is, in terms of what's right for them. But most of my patients want to start on combination antibiotics yesterday because many of them have seen that the antibiotics helped them and they were denied longer course antibiotics, and when they stopped the antibiotics, they went backwards, so they know the antibiotics work, and they seem to have more common sense than people who are following the guidelines. They seem to understand that a longer course of antibiotics is what it takes. And for any other disease, I keep on saying, if you went to your GP with an earache, an ear infection, and took a 10-day course of antibiotics, got better, then the ear pain came back again, they'd give you more antibiotics, and it's frustrating, I think, for patients to be told you can't receive more antibiotics. You've had your dose, you're cured, so most people want to start treatment right away.
Dr. Lambert, have you had folks who have not done well with the course of antibiotics because they were immunocompromised for some other reasons? For example, because they were living in a moldy environment, or because they were harboring heavy metals?
Yeah. Well, see, I'm not a functional medicine doctor. I don't, the only heavy metals I do, maybe Pink Floyd, but joking. But I don't understand. Look, but in molds, like some people think that they have molds all over their body. I think molds can affect your immune system. So it's part of the 3 I's. If you're in a moldy environment, it can damage your immune system. So you have to sort that problem. But the cure, I have a lot of patients say, well, I've got candida throughout my body. Give me an antifungal. Well, no. I still get back I get parasites. Give me a parasitic agent. I still get back to the point that Lyme is the problem here. Lyme made you immunocompromised. Let's focus on Lyme, repairing the immune system. You don't need heavy-duty antifungals for a year.
Right.
I still get back to the point that we really need to focus on the crux of the matter, the crux of the matter is a bacterial infection called Borrelia and other similar infections, co-infections, that can create this cascade of immunosuppression, immunodysfunction, reactivation of other infections, acquisition of other infections. You know, I think really that I think we really need to focus on, you know, Lyme disease, you know, and as a bacterial infection, and potentially a curable bacterial infection. The viruses we talked about are not curable. All you can do is repair the immune system to, you know, you know, put the viruses back in their cage. Unfortunately, some people just, their gut doesn't tolerate the antibiotics. That's really the only situation where, you know, I would say 95% of people can tolerate the antibiotics if you prepare the gut. But there is that 5% that just can't take the antibiotics, and that's the challenge. In that situation, IV is the only option, but it's hard to get IVs most places, and IVs are only available for, you know, some of the antibiotics, but not for most of the other co-infections. So how do you deal with that? So that is where I come up to my biggest challenge, is when patients' gut can't tolerate the antibiotics, then I can't really assess. You know, when I see patients in day one, I say 70% chance you're going to respond to the treatment, but I don't know if you have active Lyme or not. Your history is suspicious. Your blood tests look like you've been exposed to Lyme. The two interpretations are you either have an active infection or you have had an infection in the past. You know, ask me in 4 months whether you have Lyme disease. At that stage, I'll be able to see whether you respond to the antibiotic treatment. And that really is my approach, is let's do a trial of a treatment with the understanding that 70% of people respond to the treatment. If you don't respond, it doesn't make sense to push the antibiotics ad nauseum. It makes sense to step back a little bit and relook at the situation and try to go on a different avenue to get people better. I don't just kind of kick people out the door. I try to continue to work with them. And that includes working with the herbalists and others who may do a better job of managing patients if my treatments don't work.
Dr. Lambert, we really love the work that you're doing and you have been doing. We love the personalized medicine that you've been practicing for decades, although it's now becoming, you know, folks are trying to catch up to your approach to personalized medicine, but it really is, it's just a brilliant approach that you've been taking. And, you know, you've really blessed us and our listeners with so much insight. So we can't thank you enough. And we did make the commitment to you that we would not go beyond the 2-hour mark. And since we're only 3 minutes away from that, I am going to wind down the podcast by asking you how folks can get in touch with you if they wanted to work with you at your hospital.
So I have a secretary. All my emails just go through admin@iddoctor.eu. So admin for administrator at iddoctor.eu. So patients can just contact me through that. And then, like I said, if there's an international audience looking here, I also work with the Lyme Resource Center, and we're working on signage, you know, putting signs up to make people aware that there are ticks all over the UK and Ireland because they're not signs. And we're also working on education, you know, for GPs. So if people are interested, both in terms of personally for their care or volunteering for the effort, they can reach me through the admin@iddoctor.eu email.